Welcome to the Australian Dental Council Explainer podcast.
And before we dive into the material today, I just need to explicitly state that this content is purely educational, not a commercial endorsement, and is designed to aid in clinical understanding.
Right, absolutely. So imagine you're looking a terrified patient in the eye, right?
Yeah.
You're trying to keep your own heart rate steady as you explain that your specialized dental file just snapped off deep inside their tooth root.
Oh yeah, that's the nightmare scenario right there.
It really is. And today, we aren't just looking at the rigid biological reality of a tooth. We're navigating the psychological minefield of communicating those clinical realities to the person actually sitting in your chair.
Exactly. Because it's a person, not just a procedure.
Yes. So if you are an overseas trained dentist prepping for the ADC exams or, navigating dental school or currently practicing as an oral health therapist in Australia, this deep dive is built for you. We are pulling the most critical insights from Odell's clinical problem solving in dentistry and the ADC communication task scenarios.
Yeah, we're really focusing on restorative and endodontics today. So that means, diagnosing tooth wear, applying the 5 Rs of restorative repair, assessing failed bridges, and of course, managing severe root canal complications.
The fun stuff.
Right, exactly. But, technical excellence is really only half the requirement here. The true test, both in practice and for the examiners, is how you layer those physical procedures with really empathetic, clear communication.
I mean, to fix dental failures, the instinct for decades was simply to, drill and fill, right? You see decay, you obliterate it, you pack it with material.
Yeah.
But modern practice has totally shifted away from that.
Completely. We've moved toward minimum intervention dentistry.
Right, MI. Because we're trying to outrun what Odell refers to as the restorative spiral.
Yeah, the restorative spiral. It's essentially the timeline of a tooth's structural demise. I mean, you place a filling, it eventually degrades, and then, well, you have to replace it.
And to replace it, you're cutting away more healthy tooth, right?
Yeah. Exactly. You cut away another millimeter of healthy enamel and dentine just to get a clean, fresh margin, and then that larger filling fails down the road. You cut away even more, and eventually...
There's just nothing left.
Right. The structural integrity of the tooth is entirely gone. It fractures, or it needs a crown, or worse, an extraction.
So to intercept that cycle, we have the 5 Rs protocol, which kind of reads like a clinical triage system.
It really does.
First, you have review. You don't touch a stable restoration just because it has a minor inactive defect. You just observe it over time.
Yeah, just watch it. And then there is Reseal. So if a patient comes in with a localized marginal gap, instead of tearing out the whole block of composite.
Oh, just tempting.
Oh, very tempting. But instead, you apply a targeted sealant to close that specific vulnerability and, block bacterial entry.
Which leads to the third R, right?
Yeah.
Refurbish. Sometimes the issue is just surface texture or staining or like a slight overhang that traps plaque.
Right. So by recontouring and polishing the existing material, you make it easily cleanable for the patient again. But if there is an actual physical break, you move to the fourth R, which is repair.
Right, so you're only prepping the localized defect.
Exactly. You bond new material directly to the sound remainder of the old filling.
It's sort of like home maintenance, right? Like if you find a draft in your window, you reseal the frame rather than tearing down the entire wall. It stops the whole restorative spiral of destroying the house.
That's a great analogy, actually. Yeah, leaving the final R, replace, as the absolute last resort. You only tear the whole house down when the foundation is actually rotting.
Okay, but let's look at a scenario where the decay is already massive. You're excavating a very deep carious lesion, and you're moving dangerously close to the pulp chamber. The biological distinction here between infected dentine and affected dentine that basically dictates whether the tooth survives the appointment without a root canal.
Yeah, this is critical. So the infected dentine is the outermost layer of the cavity. It's necrotic, soft, heavily contaminated with bacteria, and, well, it's structurally destroyed.
It's just mush, right? It can't be remineralized.
Exactly. You must completely clear it. But beneath that mushy layer lies the affected dentin. It feels slightly softened to your probe because the bacterial acids have leached out some minerals and, it might even be stained dark brown.
But the crucial collagen matrix is actually still intact.
Right, and the bacterial load in that affected layer is minimal, so the goal is to leave it alone. The dentine pulp complex is highly dynamic.
Oh, right, because if it senses an assault from decay, the pulp tissue will actually lay down a dense protective layer of tertiary dentine, like it physically walls itself off from the acid attack.
It is a remarkable biological defense mechanism. We preserve the affected dentine precisely to protect the pulp from a physical exposure during our drilling.
But I've got to push back here, because the common reflex is to view that remaining softened dentine as like a ticking time bomb. I mean, it technically still harbors a few bacteria. So if we leave it right on top of the nerve, aren't we just burying the problem? Like, how does covering it up actually halt the decay process?
Yeah, a lot of people worry about that. But the answer lies in the mechanics of the peripheral seal. Modern adhesive composites create a micromechanical lock with the healthy enamel and the superficial dentine around the perimeter of the cavity.
Oh, so you're sealing them in.
Exactly. When that perimeter seal is flawless, you completely cut off the substrate supply. The bacteria trapped deep in the affected dentine are entirely deprived of dietary carbohydrates from the patient's mouth.
Wow, okay. So without that fuel, they can't produce acid.
Right. They either die off completely or enter a state of permanent dormancy. The lesion arrests.
That makes the integrity of the margin the single most critical part of the procedure then. I mean, if saliva, which is loaded with bacteria and moisture, touches that tooth while you're trying to bond the composite,
The adhesive will fail. The seal will immediately leak.
which is why the literature stresses that a rubber dam is non-negotiable for these deep adhesive procedures.
Absolute deal breaker. A rubber dam physically isolates the tooth, keeping the working field bone dry. Plus, if you're working millimeters from the pulp and a microscopic exposure does occur, the rubber dam prevents the millions of bacteria in the patient's saliva from instantly colonizing that sterile root canal system.
Right, you're creating a biological quarantine. You simply cannot achieve a hermetic seal in a swamp.
Beautifully put.
But, even if you execute a flawless peripheral seal, that tooth still has to survive decades of crushing mechanical force. I mean, a patient chewing 3 meals a day exerts massive stress on both natural enamel and restorative materials.
Yeah, eventually the hardware fatigues.
Exactly. Let's look at the systemic failure of, say, a spring cantilever bridge. A patient presents with a bridge that is completely debonded and fallen out. Now, the impulse might be to just clean up the cement and stick it back on, or, start cutting adjacent teeth for a new one.
Yeah, that reflex will get you into a lot of trouble, both clinically and in an exam setting. Before you even look at the design of the prosthesis, you have to interrogate the biological foundation it rests on.
Right.
You must rigorously assess the periodontal health of the abutment teeth.
So you're calculating the total attachment loss to see if the tooth is actually still firmly anchored in the jawbone. And to do that, you measure the probing depth sliding the periodontal probe down into the gum pocket, and you add that measurement to any visible gum recession.
Right, measuring from the cemento-enamel junction down to the current gum line. And you must do this meticulously at 6 points around the circumference of every potential abutment tooth.
Wow, 6 points.
Yeah. If the attachment loss is severe, the tooth becomes mobile and it cannot possibly support the lateral torque of a bridge. You also must evaluate the alveolar bone width and height radiographically.
Oh, like with paralleling periapical x-rays for accuracy.
Exactly. Or if you're considering moving to an implant, you require a cone beam computed tomography scan, a CBCT, to measure the exact bone volume in 3 dimensions.
Okay, so once you confirm the foundation is solid, then you navigate the replacement options.
Yeah.
I mean, a minimal preparation adhesive bridge preserves tooth structure, but might not withstand heavy bites.
Right. And a conventional fixed bridge requires aggressively cutting down healthy adjacent teeth for full crowns, which we just established violates the minimum intervention philosophy.
Unless those teeth are already heavily restored, right?
Correct. Or you bypass the natural teeth entirely with an implant, provided the bone density from your CBCT looks sufficient. Every choice is a compromise between tissue preservation and mechanical retention.
Speaking of mechanical retention, what happens when the natural dentition itself is wearing flat? Like a patient complains their front teeth are visibly shorter than they were 5 years ago.
That's a classic scenario.
Yeah. And the diagnostic fork in the road here is determining if the damage is attrition or erosion. Attrition is physical tooth-to-tooth grinding, usually bruxism, right? And erosion is the chemical dissolution of the enamel and dentine by acids.
Exactly. And the visual cues are distinct if you know what to look for. Attrition leaves flat, matching wear facets on the biting surfaces.
Like they fit together like puzzle pieces.
Yeah, While erosion often leaves smooth, scooped-out depressions, sometimes with amalgam or composite restoration standing proud of the surrounding melted-away tooth structure.
Oh, like little islands of filling sticking up.
Yes, exactly. And the clinical text highlights that uncovering erosion requires a rigorous 4-day dietary analysis. You have to capture everything a patient consumes to find hidden acidic habits, alongside investigating intrinsic sources like silent gastric reflux.
But wait, if you see a patient whose teeth are severely worn down, the immediate clinical instinct is to just protect the remaining structure, right? You take impressions, you fabricate a hard acrylic occlusal splint, and you tell them to wear it every night to physically block the grinding.
That is a very common reflex, but it illustrates exactly why precise diagnosis is paramount. If you assume the wear is purely attrition from nighttime grinding, issuing that splint makes total sense.
Right.
But if the actual primary driver is erosion, say the patient has undiagnosed gastric regurgitation while they sleep, that splint becomes a catalyst for catastrophic damage.
Wait, really? Because the splint acts as a physical barrier, so the stomach acid comes up into the mouth, seeks under the plastic of the night guard, and just gets trapped directly against the enamel.
Precisely. In a normal oral environment, the patient's saliva is a powerful buffering agent. It contains bicarbonate that neutralizes the acid and minerals that remineralize the softened enamel.
Oh, wow. So the plastic splint blocks the protective saliva.
Yes. It blocks the saliva while simultaneously holding a reservoir of highly corrosive acid tightly against the dentine for 8 straight hours. The rate of destruction accelerates exponentially.
That's horrifying. The treatment provided to save the teeth becomes the exact mechanism destroying them. You really have to understand the why before you prescribe the what.
Absolutely.
And that principle becomes even more critical when those mechanical forces or acidic attacks finally breach the pulp chamber. I mean, we leave the realm of restorative patching and enter endodontics. The clinical complexity spikes, and your communication skills are suddenly put under a microscope.
Especially for the ADC exams. Translating complex endodontic biology into plain, empathetic language is a strict requirement.
Okay, let's look at the scenario of irreversible pulpitis. A patient is in agonizing, spontaneous pain that painkillers cannot touch. You test the tooth and realize the nerve is dying.
Yeah, you have to deliver bad news to someone who is exhausted and in pain. The guidelines explicitly warn against relying on clinical jargon or acronyms. You do not tell a patient they, quote, need an RCT.
Right, they don't know what that means. It sounds clinical and cold.
Exactly. The most effective strategy is visual. Ask for a piece of paper or grab a digital tablet and sketch the tooth. Show them the hard outer shell and then draw the hollow canal inside where the nerve tissue lives.
You give them a visual anchor. You say, the decay has tunneled through the hard layer of your tooth and entered the hollow space inside. Unfortunately, the nerve inside that space is severely inflamed, which is causing your intense pain. It's direct, but totally accessible.
From there, you lay out the pathways forward without catastrophizing. You must present the option of extraction, physically removing the tooth to completely remove the source of infection.
And then you present the alternative root canal treatment.
Right. You explain it simply as a procedure to save the tooth by opening it up, carefully cleaning out the inflamed tissue that is hurting them, and sealing the hollow space so bacteria cannot return.
You also have to mention the option of doing nothing, just for informed consent, but you strongly caution against it, right? You explain that the infection won't just fade away. The bacteria will multiply and migrate out the bottom of the root into the jawbone, potentially causing a severe abscess or systemic swelling.
You are guiding them to a medically sound decision through clear education, not through fear.
Yeah, absolutely. But sometimes the pain isn't caused by a massive visible cavity. Sometimes a patient comes in complaining of a sharp, piercing pain only when they bite down on certain foods. They have a 20-year-old silver amalgam filling, and using a diagnostic tool like a frac finder, which, isolates chewing pressure to single cusps, you confirm they have a cracked tooth.
This is a notoriously difficult conversation because the patient usually cannot see the crack on an X-ray or in a mirror. They might feel highly skeptical of your diagnosis.
So how do you approach it?
You have to explain the mechanical history of their mouth. You validate that their silver filling was incredibly strong and did its job for 2 decades. But to mechanically lock that metal into the tooth back then, the dentist had to cut an undercut shape, leaving the surrounding tooth walls thinner and entirely unsupported.
So the amalgam didn't flex when they chewed. The natural tooth around it did. After millions of chewing cycles, the fatigue finally caused a microscopic fracture line to propagate through the remaining enamel. You aren't criticizing the previous dentist, you're just explaining material physics.
Exactly. But what if that fracture line doesn't just chip a cusp? What if you discover a vertical root fracture, a VRF, where the root itself is split straight down the middle?
Oh, man.
Yeah, the protocol for a vertical root fracture is absolute. A VRF cannot be glued back together, and it cannot be saved with a root canal because bacteria will constantly leak through the crack directly into the surrounding bone.
So you have to look the patient in the eye with immense compassion and state clearly that the tooth is fundamentally split into two pieces beneath the gum. You inform them that the only medical option to stop the infection and bone loss is extraction.
You cannot waver or offer a temporary fix that will only prolong their suffering and destroy more bone. It requires a steady, authoritative empathy.
Now, let's look at another highly charged amalgam scenario. A patient walked in demanding that you immediately drill out all of their perfectly intact silver fillings. They've been reading articles online or consulting a naturopath who convinced them the mercury in the fillings is toxic and is actively poisoning them. This feels like walking a very fine line between respecting their autonomy and practicing evidence-based medicine.
It is a true test of your emotional intelligence. You must not become combative, dismissive, or mock the source of their information.
Right, that just makes them defensive.
Exactly. You start by validating their desire to be proactive about their overall health. But then you must calmly present the scientific consensus. You explain that multiple global health organizations have thoroughly investigated this over decades, and the evidence shows that the mercury in their fillings is bound into a highly stable alloy. It is not freely leaking into their body.
The irony, of course, and the biological reality you have to explain, is that the highest risk of exposure actually comes from doing exactly what they're asking you to do.
That is the crux of the communication strategy. You inform them that mercury becomes a potential hazard when it is heated into a vapor. By taking a high-speed drill to intact amalgam to remove it, you are actively generating that vapor and particulate dust.
Right, by trying to eliminate a perceived risk, they're exposing themselves to an actual, albeit manageable one.
Exactly. If they still insist, or if aesthetics are the true underlying concern, you offer a compromise. You can replace the most visible fillings, but you emphasize that it will require strict protocols, like a heavy rubber dam and high-volume suction, to protect them during the removal process.
The danger is in the dust, not the dormant filling. Okay, let's push into the most stressful endodontic scenario outlined in Odell's text. You're midway through a root canal. The canal is curved, the delicate stainless steel file is under tension, and suddenly you hear a tiny click. A piece of the instrument has fractured and is lodged deep in the apical third of the root.
This is a clinical nightmare.
Just reading about it makes my palms sweat.
Right. The immediate rule is to stop. Do not try to blindly grab it with forceps. You will only push the fragment deeper into the canal and wedge it tighter into the dentine. The literature mandates the use of high-power magnification, like a dental operating microscope. You must be able to see the fragment clearly.
And the retrieval mechanism is fascinating. You don't pull it out, you vibrate it out. You use specialized ultrasonic scalers, equipped with incredibly fine tips. By applying the ultrasonic tip to the side of the metal fragment, the microscopic high-frequency vibrations transmit acoustic energy. This energy effectively pulverizes the microscopic layer of dentine that is gripping the file, loosening the wedge until the fragment can be flushed up and out of the canal with irrigation.
It requires immense precision and patience. But, the bigger challenge for the clinician is pausing the procedure, sitting the patient up, and explaining what just happened.
Yeah, I mean, if you sit a patient up and say, "I just broke a piece of metal inside your skull," they are going to panic. How do you meet the legal and ethical requirement for informed consent without inducing a panic attack in the chair?
It really comes down to tone and normalization. You frame this not as a catastrophe, but as a known, documented risk of a highly complex procedure. You maintain steady eye contact, keep your voice calm, and state, because the canals in your roots are so narrow and curved, the delicate instruments we use to clean them undergo a lot of stress. In very rare instances, the tip of an instrument can separate, and that has happened today.
You immediately follow the bad news with the protocol. You don't leave them hanging in the anxiety of the unknown.
Exactly. You immediately pivot to the solution. We have specific protocols for this. I am going to use a specialized microscope and an ultrasonic tool to gently vibrate it loose. If it is too wedged, we may simply bypass it and seal it into the filling, or I will refer you to an endodontic specialist who handles this exact complication regularly. You project control. You reassure them that their health is not in immediate danger, and you have a clear, actionable plan.
Okay, there is one more failure mechanism we need to cover, and it's deceptive because it is entirely silent. A patient comes in for the first stage of a root canal. You remove the nerve, place antibacterial medication in the canal, and seal the top of the tooth with a temporary filling. You tell them to come back in 2 weeks, but life gets in the way, and they disappear for 4 months.
The classic MIA patient.
Right, they finally return. The temporary filling has completely washed out, leaving the hollow tooth open to the mouth, but they feel great, no pain at all. Could you just flesh it out and finish the final root filling?
Under no circumstances, the Odell text is uncompromising on this point. If the canal system has been exposed to the oral cavity for more than a few weeks, and certainly for 3 months, you must assume complete, profound bacterial contamination.
Even if there are zero symptoms, we are dealing with microleakage, right? Saliva, food debris, and millions of bacteria have slowly seeped down the walls of the canal system, penetrating deep into the dentinal tubules.
And pain is not a reliable indicator of infection here because the sensory nerve is already gone. If you simply place your final gutta percha filling over that contaminated system, you are entombing the bacteria inside the root.
Oh, right.
They will proliferate, migrate out the apex of the root, and eventually cause a massive periapical abscess in the bone. The standard of care dictates you must completely retreat the tooth.
So you have to re-instrument the canals to strip away the infected dentine, remedicate with calcium hydroxide for several weeks to raise the pH and kill the bacteria, and establish a new, pristine coronal seal before you can ever consider the final obturation.
Yeah, it all comes full circle.
It does. Whether you are dealing with a microscopic cavity on the surface of a molar or the deepest apex of a root canal, the biological imperative is exactly the same. The peripheral seal is everything. If you cannot seal the tooth from the oral environment, the treatment will fail.
That biological imperative never changes, but the tools we use to observe it are evolving rapidly. As you process all these scenarios for your exams and your future practice, consider this final thought. Today, we discussed communicating visible, often painful failures, cracked cusps, massive decay, separated files. But diagnostic imaging is shifting. Cone beam computed tomography is becoming ubiquitous, and artificial intelligence algorithms are now routinely reading our radiographs.
Yeah, the software is getting incredibly adept at spotting variations in radiopacity that the human eye just naturally glazes over.
Indeed. Soon, AI will routinely flag microscopic, completely asymptomatic failures. It will highlight a failing restorative margin or a 2 mm periapical radiolucency years before the patient ever feels a single twinge of sensitivity. The technical reality of dentistry is advancing deep into the microscopic realm.
Which creates a massive communication hurdle. How do you look at a patient who feels perfectly healthy, who has zero pain, and empathetically convince them they need an invasive, expensive intervention based solely on a predictive computer algorithm?
The technical skills to fix the tooth will always be baseline requirements. But the burden of clinical communication, the ability to build profound trust when the patient cannot physically feel the disease, is going to become heavier than ever.
We have to ensure our humanity and our empathy scale at the exact same rate as our technology. For more dental examination prep tips and clinical deep dives, please subscribe and share this episode.